Good afternoon and welcome to the next in the MQ Health Wellness series presentations. My name's Simon Wilcock. I'm the Program Head of Primary and Generalist Care, Wellbeing and Diagnostics at MQ Health, and I'm going to be your facilitator this afternoon. The topic for the next hour, as you will be aware, is around staying on top of sports injuries. And in case we think that this is something that's really only relevant to active or professional sports people, I was reflecting this morning as I did a 5K run around my suburb, realising that my knees are old and they hurt doing certain bits and I puff more than I used to. But in my own family, my 90-year-old mother ran her last City to Surf at age 80. She's an ex-marathoner. She still walks a lot. My sons and my grandchildren are all active participants in sport. So we know that staying active is an important part of keeping both our physical and our mental health well balanced. So today our speakers are going to bring to us their advice around a number of topic areas. Firstly, though, I'd like to, on behalf of this gathering, take the opportunity to acknowledge the First Nations peoples of Australia and their elders past, present and emerging, and acknowledging that we meet on land that always has been and always will be their land. The three speakers that we have this afternoon, the order has changed slightly. I'm not sure if you've got programs there in front of you, but it's the same three speakers. But we're going to hear from Dr. Rowena Mobbs, who's going to speak about concussion events and prevention of long-term sequelae from that. We've got Mr. Chris Wynn, physiotherapist, who's going to talk about tips for prevention and rehabilitation, very relevant to all of us. And we've got Professor Sumit Raniga, who's going to speak finally about what are some of the common injuries we get, and particularly those associated with limb injuries. So the first speaker, the first presenter in this particular webinar, and we will have some time at the end for your questions, but we'll keep the questions to the end, is Dr. Rowena Mobbs, who's a cognitive neurologist and senior lecturer in the Department of Clinical Medicine. Rowena is an expert in cognitive neurology and holds a senior lecturer position at our Macquarie University Hospital and Medical School. She's an advocate for care and research in repetitive traumatic brain injury on the national stage, and has co-founded the Australian Cognitive Neurology Society and is the clinical co-director of the Macquarie University Concussion and Repetitive Head Trauma Research Group. So, Rowena, welcome, and thank you for talking to us about concussion, how we prevent them, and more importantly, how we manage after them. Thank you.
Cool. Wonderful. Thank you so much, Simon. It's an absolute pleasure to be with you here this afternoon, and I'm proudly performing the research at Macquarie University to link the clinical work that we see with patients in the neurology clinic with the research on concussion and its sequelae as well. So I'm going to talk about, I've had a concussion, now what? This is a really common question that I come across, but increasingly so, because concussion is everywhere in the media these days, it seems. And particularly around the long-term dementia syndrome of chronic traumatic encephalopathy, which is no easy term to say, so we say CTE for short. And it's things like rugby league and all of the football codes that have been shown to have this. And we know that contact collision sport's very much a part of Australian life, but we want to perform our sport safely. We want to get that balance of reducing our vascular risk for things like heart disease and stroke and dementia, with reducing head injuries and doing well from a concussion perspective. So I'd like to touch on that. Concussions are actually the most common cause of presentation in the football codes to a hospital. You can see the numbers there by the Australian Institute of Health and Welfare recently. So it is a hugely important topic to deal with. Now, what I've demonstrated here in this diagram is that it's not just the side of the head that's impacted as to where the brain injury can occur, but it can be on the opposite side. So that's what we call contre-coup, or the sort of counter-attack or counter-insult in the brain, and so that's demonstrated in the red area there. And we also know from research increasingly that there's a vibratory kind of bell ringing effect that the brain has after a concussion, and so that's really where the evidence is to suggest that, well, helmets don't, and other headgear doesn't necessarily protect you from concussion. In fact, that there's little evidence that it changes the game in that. And so we certainly need more research to understand and prevent injuries. And we're not just talking about sports, of course. It could be up a ladder that you have a fall, or other environments such as work environments that lead to concussion. Now, we're very interested at Macquarie University in terms of post-concussion syndrome and the sort of long-lasting effects after concussion. I guess it often takes a while for patients to get to see a neurologist, if at all. We are, brain specialists, but sometimes patients are missed in terms of referrals to that pathway. This thing called post-concussion syndrome, it's kind of arbitrary, beyond the 1 month or so after a concussion, where people have continued symptoms. And that ends up being about 15%, maybe even 20% of patients in some studies. And patients can very often fall into this kind of no man's land of not knowing where to go for care. And so I'd like to kind of introduce a plan today on what that preventative and treatment and management care might look like for people. And so providing some guide on that. When we talk about concussion, we're not just, of course, talking about the pain at the site of injury. Of course, it's a multitude of other symptoms as listed here. Commonly, dizziness comes into the picture. Mental clouding, fog, there could be double vision or nausea, numbness, all these sorts of features after concussion. And we now recognise, and increasingly out there in the general awareness of the community, is that women often sustain more severe and more prolonged concussion or post-concussion symptoms. Now, interestingly, I feel it's likely that some of these symptoms are due to post-traumatic migraine. So when you shake up the brain, it's not uncommon that you can trigger irritation of migraine, which is an electrical and chemical disturbance of the brain. And as listed here, things like sensitivity to light and sound and mental clouding and fatigue, all of those sorts of post-concussion symptoms can actually be identical in migraine. The message here is that a migraine is effectively treated by neurologists. You've got a whole range of therapies for that, so it's a matter of trying to treat that, see what's left after concussion, and hopefully get people back to normal, even months or years after their event. Now, in the US, it's also recognised that the majority of work in terms of CTE has been performed in those with an NFL background or American football. They've led the way in Boston to demonstrate what CTE is, and I'm commonly asked, is it actually dementia? Well, yes, it is. There may be players after repeat head trauma who remain quite stable, but then there is this percentage, and we don't know what that is in Australia, who then go into decline due to these deposition of abnormal protein in the brain and gradual shrinkage of the brain in different areas. So you can see here stage 1 to 4. And so stage 1 and 2, you might get the mood symptoms, so things like depression or anxiety or irritability that indeed could be for a lot of reasons, like life or biologically or alcohol and things like that. But often we feel this is actually due to CTE, and then it can progress into actual, frank memory loss and other changes in cognition, and eventual decline into a dementia syndrome. Now, in the US, they've demonstrated that there is this exposure effect in sport, in NFL. So the longer you play NFL, the higher your risk of CTE. So for every 2.6 years of play, the risk of CTE doubles. And particularly if you've played beyond 9 years, they feel. So your risk of CTE goes up by 30% every year. And they've demonstrated a high rate of CTE in deceased professional players. The wider population, exact incidence and prevalence is still being determined. For those who play young, so before age 12 in NFL, there's an earlier presentation of these cognitive and behavioural symptoms. And they've also demonstrated that the majority of head trauma occurs in their training environments, and so it makes sense to modify that. And they've introduced a highly effective program called Tackle Can Wait, where before the age of 14, they're not doing tackling and training. They're leaving that skill and that practice for at least mid-teens. The brain is still developing into the early 20s, actually. And so I'm interested here in Australia whether we might do similarly for our contact sports. A couple of years ago, the AIS and the Australian Medical Association and others released a position statement, concussion in sport. And just to go through that in general, they recognised, and rightly so, a patient should be removed from the field after a concussion, a player. And they should be assessed and have all the neck cervical spine precautions, have monitoring, possibly use this thing called SCAT5, which is an assessment tool. And that children and adolescents take longer to recover. and that kids should not be cleared less than 14 days from the resolution of their symptoms. They also showed that blood tests are not necessarily indicated, nor is imaging, and we have to be careful as doctors not to provide radiation with a CT scan, for example, unless there is adequate concern and indication to look for a brain bleed or something more serious. But kids and players need immediate rest. They need then a graded approach, very light intensity to their physical activity and their cognitive activity after a concussion. And that many resolve after a couple of weeks, and that if there's any doubt, sit them out and have more time to recover. But they did say that there was no strong evidence to link sports-related concussion with CTE, and I would dispute this strongly. My suggestion, or our group's suggestion at Macquarie, as possible conservative protocol changes, would be to ensure that children have at least 4 weeks off after resolution of symptoms. The reason for this is that we think that there may be ongoing brain inflammatory changes or effects of that concussion beyond when the symptoms actually resolve. And in adults, being again very conservative, you might take a couple of weeks after symptoms resolve. Children, I feel, should have a mandatory 4 weeks off play, not go back any sooner rather than the existing 2 weeks. And adults, a mandatory 2 weeks off, including that game that's, the 2 weekends, rather than going back at 11 days. And players should be offered neurology review. So we should think about brain specialist care in concussion. That makes sense, along with the team, with the general practitioners and the sports physicians. CTE is here. We need to look at that. It's the subconcussion and concussion risk over time. Remember that 9 years or more is a key figure, we think. We need to obviously do things like minimising alcohol, avoiding toxins like smoking, lowering the blood pressure to 125/80 or less for the general vascular health, to protect the brain from vascular dementia as time goes on. Treat cholesterol and have your annual checkups. But consider seeing a neurologist for annual review and an MRI brain. For those with more than a decade's head injury, a neurologist is a good idea. We can perform cognitive screening, we can monitor the patient, treat any of those symptoms I mentioned, try and also grapple with other causes of cognitive impairment and headache, like obstructive sleep apnea, migraine and mood disorders, and refer to a neuropsychologist, and I'll explain who they are in a minute. Sometimes we diagnose likely CTE, and so treating that patient like in any dementia syndrome is important. So there's a lot we can do. Things like memory medication, something called Aricept, mood stability, and providing sometimes medication for that, but often clinical psychology or environmental changes, and a lot of issues around adjustment, particularly in CTE being a young onset dementia. So many of my patients are working, they're on boards, they've got roles and responsibilities in life and young families. And so adjusting them appropriately over time to both come to terms with their situation but also adjust their work burden. So what is a neuropsychologist? So these are some of my favourite people. They help me diagnose someone. So they map out the brain for all of the function, remembering that the different parts of the brain have different functions. The front part of the brain, for example, is our decision-making centre. They're often very reassuring, so if they find no troubles and can point towards something like a pure anxiety disorder, for example, we can treat things differently. They understand the balance of cognitive and psychological factors, and they can provide tailored strategies to that person for rehabilitation. So that's all very helpful. So in summary, concussion is really common, but I would say that permanent brain damage is very rare. We don't yet know the rates of CTE, however, in Australia, and we need research for this. Women, kids and older patients may be more susceptible, and so we need to treat them perhaps more intensely and closely. Self-care counts, so take that time to rest. Remember to avoid alcohol and other toxins, and consider getting specialist care early. So the sports physician early on, followed by the neurologist for your long-term health and monitoring. So thank you very much. It's been a pleasure to talk with you today. And I'll answer any questions a bit later. Thank you.
Thank you very much for that presentation, Rowena. There's been a lot of media, not just medical media, but general media around the risks of recurrent head injuries, even single head injuries. So that information is extremely useful, and I'm sure you'll get some questions in our panel discussion later. Our next presenter is Chris Wynn, who's the lead physiotherapist for outpatient services here at MQ Health. Chris is a very experienced physiotherapist who's previously been the head physiotherapist for the GWS Giants Academy program and currently provides physiotherapy services to scholarship athletes at the New South Wales Institute of Sport. He has a special interest in the management of acute and chronic lower limb conditions, particularly those arising from sports and exercise-related pursuits, and has extensive experience in the management of those conditions and also chronic spinal conditions. He's very familiar and has worked primarily in team-based care environments, and I'm looking forward to his talk on prevention today. Thank you. Thanks, Chris.
Thank you, Simon. Thanks very much, Simon. And I'd just like to thank MQ Health for having me here to present today. I'd like to thank Rowena as well for a great talk. Concussion, obviously a big issue. So today I'm going to be talking about some tips for injury prevention and going through some rehabilitation principles. I'm going to try and keep it reasonably brief. We could probably spend a whole semester of teaching physio students some of these things. So I'm trying to go over some basic principles, hopefully that you can apply for yourselves. So a couple of things I wanted to go through. What even is injury prevention? Can we actually prevent all injuries? What does the evidence say about reducing the risk of injuries? And what strategies seem to be best for reducing injury risk? And then I'll go through some of those rehabilitation principles that I touched on. So first things first, I guess, what's the end goal? Can we reach injury zero? Is it even possible for us to prevent all injuries? You know, we talk about soft tissue injuries like hamstring strains, calf strains, Achilles ruptures. These are the things that we love to try and reduce. These are the things that we try and address in our management of athletes. You've got our horrible traumatic ones, which, you know, again, can we prevent these? It's difficult to say. We talk about the sling tackle in AFL, talking about concussion and things like that. They've made rule changes to try and reduce the risk of those injuries. And then sometimes bad things just happen. Things that are a bit out of our control, you know, that will cause injury, and they're things that, you know, we just can't do anything about. So is it even possible to prevent injuries completely? Most likely not. The evidence in the sports world would suggest that the level or the incidence of injury has remained fairly stable over the last few years, particularly in rates of recurrence. So what I would suggest there is that while the intensity of sport is probably increasing, while we're not reducing the risk of injury or reducing the number of injuries, we're certainly not getting worse at managing them. We're managing some of these recurrences reasonably well. So instead, I like to think about, rather than prevention, talking about risk mitigation. So what are some of the best ways to mitigate our risk of injury? And I'm going to start with a little bit of myth busting. And the reason I call this, I'm going to go down a myth busting pathway here, is that it's really common for us to see people who've had a soft tissue injury in the clinic, and they'll come in, and one of the first things I'll often report is, I just don't think I stretched enough before I did my exercise, and I think that's why I've strained my muscle. So good systematic review. There's been a couple of big systematic reviews looking at the effect of stretching on injury prevention or on injury risk reduction. And there's moderate to strong evidence to suggest that actually static stretching does very little to reduce our injury risk when it comes to sporting endeavours. So while I'm not anti-stretching, I'm certainly something that I prescribe and something that I use when I'm treating people clinically. It's not something that I recommend in terms of injury prevention, but certainly still useful in terms of managing in that rehab phase. But I wouldn't be using it in terms of committing time. I wouldn't be committing huge time to it from an injury prevention point of view, particularly when compared to strengthening. So the evidence is also really clear. So that 2018 paper from Lawson et al. Really quite clear that strengthening, repeated exposure, which I'll talk about in a moment, are actually really, really important and show really good effects at reducing the risk of soft tissue injuries in sporting endeavours. So it's certainly not my quote, I'm not going to claim credit for it, but there's a quote that floats around in physio circles a little bit that you can't go wrong getting strong. So if you're going to put your effort into one of these two things, then my effort would definitely be recommended to go into doing strengthening work, okay? So the other one is warm-up and preparation programs. So warm-up for sporting endeavours is a really important one. Now, I just talked about stretching. You know, in days gone by, that would have been what the warm-up was, spending lots of time with the foot up on the fence or the foot up on the bench and stretching the hammies and stretching the calves. What we're talking about here is actually getting your body ready to compete in sport or to do the activity that you want to do, whether that's swimming or running or throwing or jumping or playing football. So there's really good evidence to suggest that these preparation programs can actually reduce the risk of injury. This FIFA 11 Plus program was implemented in a football cohort and actually showed an injury risk reduction of soft tissue injuries by about 30%. So quite a significant reduction in injury risk. Now that program, the idea behind that program is that it incorporates lots of the necessary skills that athletes need in order to compete in the sport that they want to do. So it starts to expose them to the things they need. So that they include things like landing practice, so to try and reduce the risk of ACL injuries and ankle sprains and things like that. They incorporate strengthening to try and build more robust athletes. They include running, sprinting, high-speed running. They include agility drills. They include ball skill drills. They include partner drills. Now, Netball Australia has also developed their own program called the Netball Knee program with implementing similar principles. So these are preparation programs that are done throughout the year. They're done as part of the training regime, but they're also really, really useful as warm-up, taking parts of those as part of the warm-up. And so more often than not now, what you'll see on a football pitch in the warm-up is athletes doing more dynamic stretches, so actually moving through range more, trying to go towards end of range, doing running. They do things like high knees, they'll do butt flicks, they'll do crossovers, they'll do agility running, and then they'll start to do high speed to try and build up in preparation for their match. So their body's ready and primed, and also their brain's in gear and ready to go to do the skills that they need to do. The next thing is really, really important. This is the idea of that gradual progression into what you want to do. You'd never run a marathon off the back of no training. Well, you might, but it may not end very well. So our bodies are really robust. They're really, really capable of adjusting and adapting to what we ask them to do. If you challenge a muscle, it will get bigger, it will get stronger. You know, if you run and you challenge your heart, it'll get more efficient at pumping blood around your body. Tendons will get bouncier, which is a good thing. Cartilage and ligaments will get thicker and stronger and better able to deal with what you ask them to do. And ultimately bone density will improve if you challenge it enough. So it's really important to give your body time to adapt, to do the things that you need it to do. Now this slide that I've put up here is outlining an idea called the acute to chronic workload ratio, which sounds a bit complicated. But basically what it's outlining is that what you do is you take the average of your work over the previous month, and then in the next following week, you want to make sure that you're not increasing your workload too rapidly. Basically, the evidence suggests to us that in any given week after, you should be working at about 80 to 130% of your previous month's worth of workload. And that should keep you in this space where you will have a bit of a reduction in your injury risk. If you're starting to go above 150% and beyond, then you're very likely to suffer a soft tissue injury. So there's also a little bit in that in terms of it's worthwhile trying to keep the workload up so that your body can actually continue to adapt. If it's too low, then it'll start to de-adapt, which then means that you're more prone to injury also. And then recovery. Now recovery is important, but it's also important to note that you can't recover from work that doesn't get done. So if you're not training, then it's great to do recovery, but at the same time, if you're not training enough, recovery is not going to be enough to get you through doing something like a marathon or a long swim or your sporting endeavours. Now, a couple of really key points of recovery, and I'm sure Rowena would second this when it comes to concussion as well, but your big mainstays, 90 to 95% of your recovery should be made up from good quality sleep and good nutrition. Now, just touching on the nutrition, that's a little bit beyond my scope, but that would be something that I would endeavour, or I would recommend that you go in contact about dietitian or nutrition advice. But well-rounded, you know, looking at a good amount of carbohydrate, good amount of protein, You know, basically a post-match KFC or McDonald's is not really going to cut it when it comes to recovery. The other things to note are good quality sleep, so screens off about half an hour before bed, dark room, cool room is better as well, you'll generally sleep better, and trying to be consistent in your routine, particularly after exercise. But that's when our body does all its good things. What I often say is, body doesn't get stronger or fitter from the exercise that you do, it gets stronger and fitter from the recovery afterwards. That's when it's doing all its good adaptation. Now, on that note, there's a whole market now for recovery gadgets. So massage guns, compression tights, most people would have seen these, foam rolling, ice baths. These are really like the icing on the cake. The big chunk of things that you should do are your sleep and your nutrition. These are things that may help, all right? The evidence is a little bit mixed in terms of how effective these are for recovering from sporting endeavours and in terms of how much they will reduce injury risk. So they're things that if people want to try them, I'm all for them, but they're not my big chunk of advice that I give when it comes to recovery. I usually think of them as like the icing on the cake. If there's something extra that you want to do that helps, then go for it. So coming into rehabilitation principles, we're talking about tissue loading and adaptation. Most people would have heard of the RICE acronym when it comes to a soft tissue injury. They may have heard about the PRICE acronym or the POLICE acronym. We've kind of moved on to peace and love. Not that kind of peace and love. What we're talking about here is going through these when it comes to soft tissue injuries. Now, this is mainly aimed at soft tissue injuries. So we're talking about protection. It's pretty common sense. We want to try and protect the area in the early phases. If something hurts or it's getting worse with an activity, then don't push it. Give the body a chance to settle down. Elevate, again, we're trying to manage swelling there a little bit and avoid sort of too much influx of fluid into that area. Avoiding anti-inflammatories, which is a bit of one that most people would probably not necessarily know, but there's good evidence to suggest that in that first 72 hours, taking anti-inflammatories can actually have a negative impact on tissue healing. Inflammation is actually a really useful process that our body undertakes. You know, it's how our body clears out any injured tissue and then starts to lay down new tissue. So taking anti-inflammatories and trying to impair that inflammatory process in the first 72 hours can actually have a bit of a detrimental effect. We want to compress, and education. You want advice and you want guidance about what things you need to do to manage your injury. And sure, you can Dr. Google if you like, but be careful about the information that you get, and that's where it's worthwhile contacting physiotherapy to discuss what's going on. And then after that acute phase, we move into loading. So like I said before, our body's really good at adapting. So we want to expose the body and the injured area to some loading to start to get it used to what we want it to get back to. We want you to be optimistic about your injury because most of the time soft tissue injuries recover well without any long-term consequences, most of the time. We want to find options for people to maintain cardiovascular exercise. It's important to stay fit, but also getting that blood flow going is going to help with those tissues that have been injured and help them to heal and recover quicker. And then exercise, and this includes general exercise, but also specific exercises to try and allow that injured area to recover really well. And that's where physiotherapy comes in. So moving on from that, in returning to activity, we want to go into sport-specific exercise. Now, as impressive as this is not what we're talking about. We're not trying to make you do lots of weird and wacky things to try and get you back into sports. We want to train you to do the things that you need to do to compete well in your sport or your activity. So, we train agility. Right, these are just a couple of examples, but we train agility before you go back into sport. Say you've had an ankle sprain or a knee injury, we want to train agility like this, so you can go back to doing that in a game, okay? If we want to get you back to sprinting, we do sprinting at training. So in the game, you can do that. Now again, I've made this very football specific, but the same principles apply going back to running. If you want to get faster running, you need to run faster. You're not going to get faster by running slow. Okay, so a few take-home messages, a few key messages from me. I think the number one thing to try and reduce your injury risk is preparation is key. Give your body enough stimulus and time to get used to what you require it to do, and it will adapt, and most of the time it will adapt positively. If you do happen to get injured, be patient on the rehab journey. There's often setbacks or increases in symptoms. They usually don't mean that you've re-injured or that you need to start from scratch again. Sometimes it's just you need to modify your program, give your body a bit more time. We use this a lot. I could change the success note on the top there to rehab, and we use this example a lot with our patients in the clinic. No matter what YouTube says, there's never one exercise to fix all of the issues that you may have. Injuries are multifactorial. They can be genetic factors, they can be tissue factors, there can be overall well-being factors, and then there can be tissue overload factors. So it's worthwhile getting advice from someone who knows what they're talking about, not from YouTube or Dr. Google. And so on that note, if you do happen to suffer an injury, come and seek the advice of a physiotherapist. You know, I've outlined some of those rehabilitation principles there, but those are things that we spend a lot of time training and researching and practicing in our roles, and so that's where we can kind of help people. It's what we're here to do. It's what we're trained to do, is to help people recover from their injuries and give them the right advice and set them on the right path. So, finish on that one. Thank you very much.
Thank you very much.
Thank you, Simon.
Chris. As we acknowledged earlier, while we may not all be actively participating in sport all of the time, every one of us is expected to exercise to maintain our physical and also our emotional health. So the tips that you've given us around preparation, but also managing any injuries that we may sustain during those processes is very important. And I have to say, as a GP, I have many patients in their 80s and 90s who, while not active sports people, benefit from these same sorts of techniques and this advice when they're recovering from injuries associated with their normal daily exercise. Our third speaker is Professor Sumit Raniga, and Sumit's going to speak to us about common injuries and particularly how you look after your limbs when you're playing sport. Sumit is a very experienced specialist orthopaedic shoulder and elbow surgeon with 3 years of dedicated subspecialty training. He specialises now in shoulder and elbow reconstruction, arthroscopy, which is keyhole surgery, and arthroplasty, which is joint replacement surgery. His background prior to that was in molecular medicine as well as orthopaedic surgical sciences, and he has a very proven track record in cutting-edge research and is involved in developing and implementing a world-class centre of excellence here at MQ Health in shoulder and elbow research. So thank you for giving time for us today, Sumit.
Done. Well, good afternoon, everyone. It's a real pleasure and an honour to have the opportunity to speak today. And I thought what I'll do is I'll try and take you through a process of really understanding the shoulder, which is a fascinating joint. It's something I'm very, very passionate about, both through my practice and also through research, because of its unique elements in terms of the way it's structured and some of the interesting pathologies you get from it, so that you can get an understanding or a global view of how the shoulder works, what can go wrong, and then what can we do about it. And so I've brought a couple of models with me rather than give you a presentation through a slideshow, and I'll try and take you through in a three-dimensional way the anatomy of the shoulder, and then talk about some of the things that can go wrong and how we can fix them. So firstly, the shoulder is an amazing joint, and I think any one of you out there listening at the moment who's suffered from shoulder pain or restriction of range will know that the shoulder is key to function in life. If you can imagine the amount of range of motion that the shoulder gives you, it allows you to go low, reach up high, get around your back. To be honest with you, if you don't have a shoulder that's functioning well, whether that be because of pain or restriction of range of motion, it's actually really hard to use your hand. So the hand function can only be capable of providing you with life's abilities if the shoulder functions well. Without the shoulder, it's very difficult to do this. And if you think about the shoulder and the range that it affords, you realize very quickly that the anatomy of the shoulder has to be very different from the hip and knee joint, which is quite constrained, while the shoulder is very unconstrained because of the range it allows. And that's where this model comes in. If you have a good look at this model, You've got the front, the side, and the back of the shoulder. And I'll just turn it around so you get a bit of a perspective on the shoulder in 3 dimensions. This is the scapular blade. This is what we call the glenoid, or the socket of the shoulder joint. And this is the humerus, your upper arm, that articulates with it to give you all the movement and function. If you carefully look at the shoulder, the one way that I speak to my patients or educate my patients around the shoulder anatomy is to think about a surfboard with a golf tee and a golf ball on it. Now, if you imagine that in 3 dimensions, you realize that you need to have the surfboard pretty stable so that the golf ball can stay on the golf tee. Otherwise, it really is a very unstable environment where lots of things can go wrong. And in order to control the shoulder, which is so uniquely structured, you actually need to have an amazing nerve supply. And hence, when you have shoulder problems, it can be very painful. And a lot of the patients that come to see me complain of night discomfort, where they cannot sleep at night when their mind is quiet because the shoulder starts screaming. So that's the structure of the shoulder. Remarkable range, inherently unstable, and if you put it all together with the nerve control, it's almost like a symphony actually. The bones, the ligaments, the tendons, the muscles, everything needs to work almost like clockwork, like a symphony, to perform the way it does. Because if you don't have a few elements working as well as they should, the shoulder doesn't work properly and it screams with discomfort. When you think about the shoulder, there's 3 major levels where things can go wrong. The first is the joint surface. This is a beautiful anatomic total shoulder replacement model, but if you kind of ignore that and you think about the cartilaginous or the smooth lining of the joint on both sides, this is where people get the common problem of arthritis, where you start over time losing cartilage. And the issue with losing cartilage is that it does not regenerate, it doesn't come back. The only thing arthritis does with time consistently is get worse. And sadly, the rate of progression we cannot really have an understanding on. Some people it may be quicker, others it may be slower. Certainly trauma, where you've had injury to the joint, where there's been a fracture through the joint, can increase the risk of arthritis. But a lot of us suffer from arthritis with time, and some people have a strong genetic predisposition towards this. If you suffer from arthritis, obviously you can have non-operative management with physiotherapists, you can have injections to give you some pain relief, you can take pills. But at some point it gets so debilitating that you lose the range and the ability to function, you have a lot of pain, a lot of sleep disturbance, and that's where patients come forward for a definitive surgical solution. And that's where surgery can have a role by replacing your shoulder like this and being able to restore the range of motion and give you pain relief. And that's the main goal of shoulder replacement surgery or shoulder arthroplasty. The next level of pathology is at the level of the shoulder joint capsule. Every joint in the body has a capsule lining it. It is a thin but strong structure where the ligaments insert, it's fluid lined, and it gives you that ability to carry out movements with some degree of constraint and stability. One of the very common problems in shoulders is a frozen shoulder, or what we call adhesive capsulitis in medical terms, where for some reason the shoulder joint capsule actually gets filled with new blood vessels, and these new blood vessels are then surrounded by nerves that supply the very new blood vessels, but they're full of molecular substances that cause pain. And every time you stretch your shoulder joint capsule when you try and move, it hurts a lot. In fact, it's one of the most painful conditions of the shoulder. It's idiopathic. We don't know why it occurs, but there may be a genetic predisposition. The other thing that's interesting about capsulitis is that if you get it in one shoulder, you will never get it in that shoulder again for the rest of your life, but you have a 20 to 30% risk of getting it in the opposite shoulder, and that risk goes up if you have diabetes or if your thyroid gland is not working well, and there's a strong association with that. The problem with this condition is that it presents just like arthritis, where people have significant restriction of range and a lot of pain, a lot of night discomfort, but your joint surfaces are pristine. It's a molecular condition with a biomechanical manifestation. And sadly, we don't actually have any treatments for that as yet. All we can do is give you some corticosteroid local anesthetic injections, we can do some physiotherapy, and then some people require surgery, which is arthroscopic surgery, keyhole surgery, to release the joint to give you that movement back. I can tell you that here at Macquarie, we've just patented a molecular therapy for adhesive capsulitis, frozen shoulder, and hopefully in the next year or so, we will be running a clinical trial here, and we'll be able to help people better with this condition. The thing about this condition is it takes time. If you look at the evidence, it takes 18 to 24 months before you can actually get some resolution of the symptoms. And there's three very clear phases. The first phase, lots of pain and stiffness, then the pain disappears, you're just left with stiffness, and then slowly it thaws out and your movements come back. So that's adhesive capsulitis or a frozen shoulder. The next layer to talk about is the rotator cuff and the biceps tendon. Lots of people talk about the rotator cuff. In fact, I have a lot of patients that come to my clinic and they don't say rotator cuff, they say rotor cuff. It's the short form of rotator cuff. But sadly, a lot of people don't really understand what it involves, what its function is, and what can go wrong with it. So let me take you through that. The names are not relevant, but the principles are. The rotator cuff is a group of 4 muscles and tendons that surrounds the entire shoulder. It actually has a very, very important role in stabilizing the shoulder within its centrum. Biomechanically, the shoulder can only function if it's well centered within its socket. As soon as it starts moving around, it doesn't work well. It's just simple biomechanics. And the rotator cuff has a significant role in that. But as well as that, each part of the rotator cuff also instigates certain movements. For example, the one in the front, subscapularis, helps you reach around your back. The supraspinatus, which is the most commonly injured, helps you elevate up and reach up here. The infraspinatus anterior minor helps you externally rotate. So they have key roles in terms of movement as well. And this is common pathology we see, and it can be degenerative, where with time you get tears through your rotator cuff causing problems, or you can get tackled in the rugby field or have a big fall and tear it all apart. Both those disease processes, even though involve the same structure, the rotator cuff, actually have different treatments. If you have a degenerative process which happens with time, my physiotherapy colleagues can make a huge difference to your shoulder function. But if you have a full thickness traumatic tear where the tendon is pulled right off the bone, it's a very different process and it may require surgery. And we assess each patient depending on how they've done it, what the pathology is, and what the symptoms are. But what we've learned is that if you're high functioning, not really, I wouldn't say age is a factor, but high functioning and you've had a traumatic tear, you should try and see a surgeon and get an opinion, because there is a chance with that traumatic tear it will not heal and it may need surgery. And we're learning more about that, because we're learning that if you have full thickness rotator cuff tears which are left for long periods of time, it causes significant dysfunction in the shoulder where it becomes unstable in some degrees, and it cause arthritis, and they can also become unrepairable. So we've learned a lot about rotator cuffs, and we used to sort of treat them with a degree of benign neglect in the past, but the information and the knowledge around that has changed. So be very wary of seeking an opinion early if you've had a fall and all of a sudden you can't do things you could. The other thing to think about is the long head of biceps. The biceps is very, very close to the shoulder. Whenever you have rotator cuff pathology, the biceps can be involved. In fact, the biceps has 2 tendons, that's why it's called biceps. The short one inserts outside the shoulder, doesn't have much relevance to the shoulder, but the long head runs in this very groove. And people with rotator cuff pathology also have biceps pathology, which we sometimes need to treat. That just gives you a bit of an understanding of the common problems we get with the shoulder. Obviously, the shoulder can become unstable in sports people, and that's a sort of a more specialized issue that we can talk about if you have any questions around that. In terms of treatments, we've got physiotherapists like my colleague Chris. We can have injections, we can have pain relief. Then we have arthroscopic surgery, which is keyhole surgery, where we can do reconstructions just using stab wounds and being able to work inside the joint. And then we have open surgery for certain conditions. And then the last is shoulder replacements. There are 2 different types of shoulder replacements. There's this one, which is designed for people who have an intact rotator cuff, but lots of arthritis. And this type of replacement works beautifully for providing pain relief and range of motion. And then we have this one, which is also known as a reverse total shoulder replacement. And you can see the design is quite different. The ball is at the top and the socket's at the bottom. And this is designed specifically for people who have degenerative rotator cuff tears or rotator cuff tears that cannot be treated, and then they develop arthritis, but they don't have the rotator cuff tears to drive the shoulder replacement. So this type of replacement is driven by the big deltoid, and it's designed specifically for people who do not have a rotator cuff tear but have arthritis. And that gives you a bit of an understanding of the various spectrums of pathology in the shoulder, the key common ones that involve most of the people that I see, and what we can do for them. Thank you very much.
Thank you very much, Suma. We're going to have a short video presentation now, and then we'll return to the panel for questions. Thank you.
We are eyes. We never stop searching. We are hands, warm like blankets and still with certainty. We are ears, loud or soft, we always hear. We are feet, carrying us on your journey. We are arms, always ready to fight. We are the fuel that supports body and mind. We are the brain. We'll never give up trying to understand. We are the heart. We beat with one purpose. In an Australian first, MQ Health integrates world-class clinical care, teaching and research with one goal in mind: to deliver the best for our patients and our community. We are MQ Health.
Welcome back. We've now got the opportunity to direct some questions to our panellists, and I'd like to thank them all on your behalf for those presentations. Please use the question facility that you've got there and register those questions. But while we're collating those, my first question that I'd like to put to Chris is one that I deal with quite a lot in primary care, and often with young athletes, both male and female athletes, who talk about wanting to bulk up. And it relates to the issue, and I think, Chris, you emphasise the importance of strength. But what does strength mean in terms of bulk? Does it mean the more muscle you've got, the better? Or are there ways of balancing strength and flexibility and function?
Yeah, so ultimately it comes down to the sport and the activity that they want to try and compete in. There is some evidence to suggest that actually rapid weight gain, and whether that's rapid weight gain in muscle, can actually be a cause of overload. So they can develop more things like tendinopathies, and it's a bit of a factor in hip and groin pain in footballers in particular. So ultimately it comes down to finding a bit of a balance in terms of getting stronger and I guess more capable for the things that they need to do in sport. So targeting the muscle groups that they need to sprint, so things like hamstrings in sprinting sports, things like adductors and quads and all those things where they need to jump and be agile, things like core strength and things like that, so again more for performance. So yeah, there's a bit of a balance between trying to bulk up and then trying to get strong. They're sort of two different, I would class them as two different things. But look, obviously as you get strong you're going to grow muscle as well, but that idea of putting on huge amounts of muscle from a sporting context is not really ideal. And most of the time when you're training to try and bulk up as such, it's not going to translate into an improvement in strength for performance as much.
Oh, good. Thank you for clarifying that. And Rowena, in terms of concussion, I'm sure you get asked by patients, but also the families of those patients, what are the sports that I should avoid, or what are the sports that have lower risk of concussion? But probably even more importantly, at what point do you suggest to patients that they might want to consider a change of sport or the way in which they conduct that sport?
It's such a tricky question, this one, isn't it? The top sport as far as head injuries go, of course, is boxing. I'm not sure I can bring myself to advise people to box.
Right.
It's part of our community at Current, and if we banned it, I'm not sure what it would probably happen anyway. In terms of sport, we all love it in Australia. There's exciting games, and there's a lot of good things about sport. And so it's really a balance of getting to know the individual and their motivations for engaging in that sport in the first place, what they would do alternatively. And many great athletes might even look at a coaching role or administrative role, something to go to, or another sport. Could they go and play hockey, for example, or something a little lower risk than things like football. AFL, can have all sorts of injuries. I mean, all the codes have a risk. Soccer, probably a little less risk as far as head injury goes.
There's been quite a lot of media around heading the ball in soccer. And what's your comment on those sorts of issues and controversies that come up sporadically? Is there any research that can advise us around that?
Yeah, well, in the UK they've demonstrated a dementia risk at baseline for soccer players. Of course, in the old days they had the heavier ball that they were heading, and of course that had greater risk. But heading, yes, there's evidence that does contribute and accumulate, and so I am an advocate for avoiding heading in children, and I think we should probably leave it up to the age of 16 at least, with more brain development and the right to medical consent to determine what they want their risk to be.
And has there been any move by the various sports organisations to sort of adopt that and mandate it? Because ultimately the way they define the rules determines what happens on the pitch.
The response is variable at this stage, to my understanding. From the outside to the sports, what I can see is that there's a push towards age 12 or less to modify heading, and I think in general the community are taking that on board themselves to try and avoid that. But I don't think it's mandated across the board, and as I say, probably it's even after that we should look at heading the ball.
Thank you. So most of the patients I see with shoulder problems are older patients, and we often refer to the term of shredded their rotator cuff. They're often just a multitude of sort of age-related tendon tears. But we also see shoulder injuries commonly associated with certain sporting activities. Can you comment to the group on the sorts of injuries you see associated with different sports and how you manage them?
Yeah, I think one of the common things I see is shoulder instability, or a shoulder that's no longer stable, and that's usually associated with contact sports. Rugby is a key element to that. What actually happens with that is that they go into a collision environment, and rather than hitting heads, they hit shoulders, for example, and the shoulder comes out of joint. When the shoulder comes out of joints, by definition, you have torn the ligaments that stabilize the joint. And in fact, in the shoulder, they're almost hammock-like. They covet the shoulder, they keep it in position. And when you come out, you by definition have ripped those ligaments. What can happen is that with time, if that is not treated, especially in someone less than the age of 23, the risk of redislocating over your lifetime is well over 92%, Simon. Which means that every time your shoulder comes out, you're grating the cartilage on both sides, which by definition means that your risk of arthritis also goes up. And obviously you can't participate in that collision environment again because you have an unstable shoulder. And so that's something we see a lot of. And the treatment for that depends on what the pathology is. So if you've got someone who's had lots of dislocations, what happens with time is you start losing bone. Because you come out and sit in a particular position, you lose bone in the front of the socket, and you lose bone in the back of the head as well. And if you lose bone, that's another stabilizing effect that's disappearing with time, and so you have to do more complex reconstructions for those. So that's one. One of the other things I see is the young people trying to bulk up. The bulking up leads to a lot of overhead lifting, and they actually cause AC joint injuries, where they basically, the AC joint is their acromioclavicular joint, sits in the roof of the shoulder. It's a very key stabilizer for elevation and overhead positioning. And with time, that joint becomes irritable, there's a lot of inflammation, and then you get destruction of the joint. And so that's something we see. And we can treat that non-operatively for a little while, but a lot of people come back, and then we need to excise the AC joint to give them definitive treatment. And then obviously, any of the sports.
Swimming's very popular in Australia, so what sorts of injuries do you expect?
Rotator cuff injuries. So rotator cuff tendonitis, biceps problems. Anyone who does overhead activities repetitively, whether they be swimming or squash players, tennis players, that can all cause rotator cuff pathology, which we've spoken about, and also biceps pathology. Throwing, cricket. Throwing injuries are a spectrum of injuries that come from the shoulder, whether it be rotator cuff as well as biceps. So all of these problems can occur in various sports, more so in other sports than others, but the major one is shoulder instability in our Australian environment with the collision sports, and we see a lot of that.
Thank you. We've got a question here from one of our audience, and it's to you, Rowena. Is there a magical number of concussions that are too many concussions? And I guess that leads to the question of when do you consider advising somebody to leave that particular sport?
Yeah. Another great question. In the absence of having the exact science on what's occurring in the brain microscopically, right? Nobody has that as far as inflammation and bruising in the brain microscopically after concussion. In the absence of that, going, I guess, symptomatically, if someone's having more easily sustained concussion with an acceleration or amplification of their symptoms or an incomplete recovery, or they're starting to face that repetitive head trauma risk. You know, I see people with 10, 20, 50, 100 concussions, of course, then you're starting to consider that's too much. Just being careful and conservative in the absence of clear testing and imaging to tell us that there's a problem microscopically, as I say. So if it were me, I think, you know, I think if you're looking at, oh, you've had 5 or more concussions, well, maybe it's time to rethink things.
Or modify what you're doing so that your risk of concussion reduces significantly.
Or just take a season off.
Yeah.
Why should we have so much pressure to play? It has to be a careful decision with the individual to think more widely and carefully. Yeah.
We don't have any other questions at this point, so I'm going to thank each of our presenters this afternoon for their excellent presentations. They're all involved in cutting-edge research into the effects, the positive benefits of the sporting activities and other activities that we undertake every day, but also the potential injuries and risks associated with those activities and how we can mitigate and recover from any associated injuries. So I'd like to thank the 3 speakers, Rowena, Chris, Sumit, on your behalf, and I'd also particularly like to thank the MQ Health team, who you haven't met today but have been behind the scenes, made it possible to do this webinar this afternoon. Enjoy the rest of your day, and thank you very much for participating.